Welcome back to the deep dive. Today, we're plunging into a really significant challenge in oncology, the fight against metastatic non-small cell lung cancer, MNSCLC. It's a diagnosis that, for a long time, has been incredibly tough. So the search for therapies that give patients not just, more time, but better quality time is just relentless.
Absolutely. It's a constant push for progress.
And that's exactly our focus for this deep dive. The long-term overall survival results from a major clinical trial, the phase 3 POSEIDON study. We're not just talking initial findings here. This is about sustained benefit over 5 years.
Which is a really meaningful time frame in this disease setting.
Definitely. Our source today is the latest 5-year data published in the Journal of Thoracic Oncology. So our mission is to unpack what these, well, quite durable results mean for patients and how they might shift treatment, particularly for those, harder to treat types of lung cancer.
Right, let's get into it.
So just to set the scene a bit, for MNSCLC patients without those specific EGFR or ALK mutations, immunotherapy regimens are sort of the standard now.
That's the backbone, yes.
But, and this is key, not everyone responds the same way. There's variability, which really underlines the need for, well, better options, optimized regimens.
Exactly. We need strategies that work for more people more effectively.
And that brings us to POSEIDON. The trial's official number is NCT 031-64616. It was a big one, global, randomized, phase 3, over 1,000 patients.
1,013 patients, to be precise, a substantial cohort.
Right. And they were randomized 1:1:1, so 3 arms. First arm, tremelimumab, that's a CTLA-4 inhibitor, plus durvalumab, a PD-L1 inhibitor, plus standard chemo. We'll call it T plus D plus CT.
Combo.
Yep. Second arm, durvalumab plus chemo, or D plus CT.
The doublet immunotherapy plus chemo.
And the third arm was the control, just chemotherapy alone, platinum doublet.
Standard care at the time for many.
And importantly, they stratified the randomization, right, based on PD-L1 levels, disease stage, histology.
Yes, that's crucial for making sure the comparisons between the arms are fair and balanced.
Okay, let's unpack this. After all that, with a median follow-up over 5 years, 63.4 months, what did we actually learn? Let's start with T plus D plus CT versus chemo alone.
Well, the headline finding is a statistically significant and sustained overall survival benefit for the triple combination.
Sustained is the key word there.
Absolutely. We're seeing a 24% reduction in the risk of death. That's a hazard ratio, or HR, of 0.76.
And just quickly for listeners, that HR 0.76 means patients on the triple combo were 24% less likely to die during the study period compared to those on chemo alone.
Precisely. And when you look at the actual survival rates at 5 years, it becomes even clearer. For the T plus D plus CT group, the 5-year overall survival rate was 15.7%.
Okay.
Compare that to the chemotherapy arm, where it was just 6.8%.
Wow, so more than double the chance of being alive 5 years later. That's significant.
It really is. Now, looking at the D plus CT arm versus chemo,
The doublet IO chemo combo.
there was a trend towards improvement, consistent with what we'd seen before. The HR was 0.84.
So a 16% reduction in risk, roughly.
Yes, and the 5-year OS rate was 13.0%, so better than chemo alone, but it didn't quite reach that same level of statistical significance as the triple combo in this long-term analysis.
Got it.
But what's fascinating here, I think, is the durability. It's not just about the numbers, but how long that benefit lasts.
Right.
It's something that really highlights the impact of that initial T plus D plus CT treatment.
Yep.
Look at subsequent therapies. Patients in the chemo alone arm, well, about a third of them, 33.2%, went on to receive subsequent immunotherapy later on.
Okay. Which makes sense if the chemo wasn't enough.
Exactly. But in the T plus D plus CT arm, only 7.4% needed subsequent immunotherapy.
Ah, interesting. So that initial, more intensive treatment maybe set them on a better path long term, reduce the need for later interventions?
That's certainly what it suggests. A more profound lasting effect from the get-go, like building a stronger foundation, as you said earlier.
Okay, so that's the overall picture, but these big trials always dig deeper, right, into subgroups.
Absolutely. You have to peel back the layers to see who might be benefiting the most or differently.
So what about tumor type? Squamous versus non-squamous MNSCLC. Did the triple combo work differently there?
It did seem to. The OS benefit with T plus D plus CT versus chemo was more pronounced in the non-squamous group.
More pronounced how?
The hazard ratio there was 0.69, so a 31% reduction in risk of death.
And the 5-year survival rates.
For non-squamous, it was 20.5% with T plus D plus CT versus 9.1% with chemo. That's a really substantial
And
difference.
we're double again. Okay. And for squamous, we know that's often tougher to treat.
It generally is, yes. 2 plus D plus CT still showed a benefit there, definitely. The 5-year OS rates were 7.3% versus 2.9% for chemo.
Still an improvement, but the difference looks smaller compared to non-squamous.
It does. The HR for squamous was 0.85, still favoring the triple combo, but less dramatically.
Any idea why?
Well, this raises an interesting point. It's possible, and the source mentions this, that the type of chemo used more often in the squamous group, maybe more gemcitabine doublets, might have influenced those specific results slightly. The chemo backbone itself can play a role.
Okay. That makes sense. What about PD-L1 expression? That's usually a big factor for immunotherapy.
It often is, yeah. But here, T plus D plus CT showed an OS benefit pretty much regardless of PD-L1 expression level.
Even in the PD-L1 negative or low groups.
Yes, including patients with PD-L1 tumor cell expression, or TC, less than 1%.
And that's notable because
Because that PD-L1 less than 1% group is often, well, relatively resistant to single-agent anti-PD-1 or PD-L1 therapy.
Yeah.
Their tumors aren't displaying that target as much.
So seeing a benefit here is quite promising for those patients.
Very much so. For that specific subgroup, PD-L1 TC less than 1%, the 5-year OS was 6.1% with T plus D plus CT versus 4.0% with chemo alone.
So still an advantage, even if the absolute numbers are lower in that tougher group.
Exactly. Though, it's important to remember, especially when looking at these subgroup survival rates at 5 years,
Yes.
the number of patients left in some of these very specific subgroups can get quite small by that point.
Right, so the percentages might have more uncertainty.
Precisely. That's why relying on the hazard ratios and their confidence intervals across the whole study period gives you a more statistically robust picture of the treatment effect for these subgroups. The landmark rates are useful, but the HRs are generally more reliable.
Got it. Good point. Now, the study went even deeper, didn't it, into the actual genetics of the tumors?
Yes, and a real strength here was the sample collection. They managed to get evaluable tissue or ctDNA, that's circulating tumor DNA, from blood samples for analysis from over 96% of patients.
Wow, that's impressive. Allows for some really detailed molecular work,
Absolutely, and to let them look at specific mutations.
like STK11 and KEAP1. I know those often mean bad news.
They often do.
Yeah.
They're associated with poor prognosis and what we call an immune cold tumor microenvironment.
Okay, can you just quickly explain immune cold for our listeners?
Sure. Think of the tumor environment. An immune hot tumor is one where the immune system's T cells, the soldiers, are already there trying to fight the cancer.
Okay.
An immune cold tumor is, well, cold. The T cells aren't really getting in or they aren't activated. It's like the immune system isn't recognizing the threat properly.
So therapies that rely on boosting an existing immune response, like just PD-1 inhibitors, might not work as well.
Exactly. These tumors tend to be resistant to single-agent PD-1 or PD-L1 blockade.
Okay, makes sense. So for these notoriously difficult immune cold tumors with STK11 or KEAP1 mutations, what did Poseidon find with the triple combo?
This is where it gets really interesting. T plus D plus CT showed a clear OS benefit compared to chemo alone.
How clear?
Okay, get this. For patients with non-squamous tumors carrying an STK11 mutation, the 5-year OS with T plus D plus CT was 12.9%.
And with chemo alone?
0%.
0. Wow. Okay, and for KEAP1 mutations?
Similar story, really. Across all patients with KEAP1 mutations, the 5-year OS was 10.0% with T plus D plus CT versus, again, 0% with chemo alone.
That's genuinely remarkable. It's opening a door for patients who seemingly had no long-term options based on those mutations.
It really suggests this combination can overcome some of that inherent resistance.
What about KRAS mutations? Those are common, but also quite diverse.
Yes, they are. And T plus D plus CT also showed an OS benefit in the KRAS mutated non-squamous subgroup. The HR was 0.55.
So a 45% reduction in risk? That's substantial.
Very. And the 5-year OS was 21.7% with T plus D plus CT compared to 8.1% with chemo.
And did it matter which KRAS mutation, like G12C versus others?
That's another key point. The benefit was seen across different KRAS subtypes, including both the common KRAS G12C and the non-G12C types.
Yeah.
Importantly, this included benefit in patients with KRAS G12D mutations.
And why is G12D significant?
KRAS G12D is another one often associated with that immune cold phenotype and tends to have poorer outcomes with just single-agent PD-1 or PD-L1 therapy.
So the triple combo seems to be hitting these hard-to-treat mutation types effectively. Any idea why? What's the mechanism?
The thinking, the mechanistic rationale, really points towards the addition of tremelimumab, the anti-CTLA-4.
How does that help in these cold tumors?
Well, CTLA-4 is basically a brake on T-cell activation. By blocking CTLA-4 with tremelimumab, you're essentially releasing that brake. This can lead to broader T-cell activation, potentially allowing the immune system to recognize and attack tumor cells that it wasn't seeing before, especially in these colder, less immunogenic environments. It might lower the threshold needed to kickstart that immune response.
So it's like adding a different kind of fuel to the immune system, one that works even when the tumor itself isn't waving a big red flag via PD-L1.
That's a good way to put it. It broadens the attack, potentially overcomes resistance mechanisms seen with PD-L1 blockade alone.
Okay, this is all really exciting efficacy data, but we always have to talk about safety. Especially adding a third drug and an anti-CTLA-4 early on. Any new concerns with the long-term follow-up?
That's always critical. But the good news is, no. No new safety signals emerged in this 5-year follow-up. The safety profile of T plus D plus CT remained consistent with what was seen in earlier analyses, and it was generally considered manageable. The early, limited course of tremelimumab seems well tolerated in this combination.
That's reassuring. Okay, so putting it all together, how does POSEIDON fit into the bigger picture of lung cancer treatment?
Well, if you look broadly, these durable OS benefits we're seeing with T plus D plus CT definitely align with the positive long-term trends seen in other major immunotherapy trials, like various Checkmate and Keynote studies. We are seeing immunotherapy combinations genuinely extending survival long-term for some patients.
That's encouraging, a consistent trend.
It is, but a necessary caution.
Yeah.
You can't really do direct head-to-head comparisons between different trials because the designs, the patient populations, even the subsequent treatments allowed can all differ.
Right, apples and oranges sometimes.
Exactly. That's why focusing on measures like the OS hazard ratios within a trial, like that 0.76 for T plus D plus CT versus chemo in POSEIDON, is probably the most reliable way to gauge the added benefit of a specific regimen.
So what's the bottom line for patients and the doctors treating them right now? What are the implications?
I think these results provide really strong support for considering T plus D plus CT as a first-line option for metastatic NSCLC,
Especially for certain groups.
especially for some of those subgroups that have historically been challenging, maybe lower PD-L1 expressors, or potentially those with mutations like STK11, KEAP1, or certain KRAS types where single-agent IO might be less effective. This offers a potent alternative.
It feels like a significant step forward, particularly for patients who didn't seem to benefit as much from earlier immunotherapy approaches.
I agree, it expands the options and offers potential for durable benefit to a wider group.
And what's next? Is research continuing in this area?
Oh, absolutely. Building directly on POSEIDON, there's an upcoming Phase 3b trial called Triton. The number is NCT 06700000993. Triton is specifically designed to look more closely at T plus D plus CT efficacy in non-squamous MNSCLC patients who have STK11, KEAP1, or KRAS mutations, including co-mutations.
Ah, so focusing even more tightly on those genetic markers. Why the focus on co-mutations?
Because while POSEIDON gave us fantastic data on individual mutations, the numbers of patients with specific combinations of mutations, say STK11 and KRAS, were too small to draw firm conclusions. Triton aims to get more data on those specific, complex genetic profiles.
Got it. Refining the picture even further.
Exactly. Deeper understanding of who benefits most and why.
Okay, so let's try and wrap this up. Recapping our deep dive today, the really standout finding from the 5-year POSEIDON update is that clear, durable, long-term survival benefit with the T plus D plus CT combination tremelimumab, durvalumab, and chemo.
Yes, particularly notable is its effectiveness in some of those patient groups that have traditionally been very difficult to treat, like those with specific mutations or low PD-L1.
It feels transformative for those groups.
It certainly has that potential.
So as a final thought, this deeper dive into the genetic landscape, understanding how mutations like STK11, KEAP1, and KRAS subtypes interact with these combination immunotherapies, does this signal a shift towards even more personalized treatment?
I really think that's, we're moving beyond just PD-L1 status or broad histology and getting much more granular. Understanding the underlying biology, the immune coldness, the specific escape mechanisms, and then matching that with combinations like adding CTLA-4 blockade that might specifically counteract those issues. That feels like the direction we're heading. It makes you wonder.
Yeah.
As we continue to unravel these genetic complexities and immune interactions, what other combinations, maybe targeting different checkpoints or pathways, might unlock similar benefits for even more specific patient profiles down the road? The potential for tailoring therapy seems huge.
A fascinating thought to end on. It really highlights how far we've come, but also how much more there is to learn in truly individualizing cancer care. Thank you for walking us through that.
My pleasure. Certainly an exciting time in lung cancer research.